illustrate for you is going through a complete physical assessment. I'm going to talk through as I do things, and that's the sort of thing I would expect for you to do when you go through and do your complete physical at the end of the course. Before I start the physical, I have Beth has come in. She's had her vital signs obtained, temperature, pulse, respirations, blood pressure. Blood pressure's been done in both arms in one position, and then in one of the arms in a standing position and either sitting or lying position, so I can evaluate for hypertension. Also, she's had her height and weight done. If she were a child, I'd get percentiles on height and weight. Throughout the exam, I'm going to be looking at her skin, and I'm not going to mention that with each system, but for skin, I'd be looking at color, moisture, temperature, texture, looking for any lesions, scars, testing turgor, and I'll just, turgor would just be pulling up. You can do it on the forearm, on a baby, you'd want to do it on the abdomen, and on an elderly person, the forehead is the best place to actually test for turgor. So testing for turgor, and I would do that like at the beginning. Okay, and I'll keep that in mind throughout the exam as I go through. Okay, the other thing is mental status assessment or mental status exam. I would really start that during the history, and I would continue that throughout. I would look at basically the categories of emotional stability, speech and language skills, cognitive function, and then also evaluate the appearance and behavior throughout the exam. Cognitive function, I'd use mini mental status would be a good test to use to do that. So I won't go through those aspects as we go through the exam. Okay, in terms of general assessment, I've watched her as she's come in, I've looked at her during the history, and I've sort of assessed head to toe for any blatant abnormalities. She seems to be in no acute distress. She's having no problems at this point in time. Her eye contact is good. Her verbal and nonverbal responses were appropriate. So at this point in time, I'll go ahead and start and do basically head to toe. Now, I typically will start out looking at the hands. I'll do capillary refill, pinching, looking for capillary refill, be sure it's brisk. I'll also look for clubbing at that point in time. And then I'll progress. I want to inspect and palpate everything as I go through. I'll just sort of feel for tone, palpate up the upper extremities. Okay? At this point in time, I'm going to go through and I'm going to do range of motion of the upper extremities per se. So what I want to do first is just having her to actually move for me. Okay, Beth, I want you to spread your fingers apart, put them back together. Okay, make a fist, straighten it out. Okay, take your thumb and move it through the, okay, and on your other side. Okay, wrists up and down and sideways. Okay, flex your arms up and out. Okay, bring your arms back behind you. Okay, and out in front of you. Out to the side, down. Okay, take them up over your head and put them back behind your, clasp your hands back behind your neck, okay? That's fine, you can come back down. That's basically giving me range of motion of her arms. At the same point in time, I can also do range of motion of the neck. You touch your head, chin to chest, chin to here, chin to there, and all the way back. All right, now I go through those same things, putting resistance so that I can test for strength. Okay, okay, all right, don't let me push them together. Okay, put them together, try to spread them. Okay, put your thumb like this, don't let me pull it out. Okay, now I can also do grips. Okay, don't let me pull it out. Okay, and then I'm going to only go on the one side. Let me just use this side as I go up. I'm only going to do one side, but you would want to do symmetrical testing from side to side. When you do your exam for checkoff, you could also do one side, but you need to say that you're going to illustrate on one side, but you would always look for symmetry between sides. Stabilize the joint that is proximal to the one you're testing. Okay, I want you to bring your wrist up. Press your wrist down. Bring it out to the side. Okay, a little crepitus there. Bring it in toward me. Okay, I want you to pull your arm up, flex it up toward you. Okay, and push it down. Okay, I want you to bring it up toward me and back, down, toward the back. Just pull it back toward that way.
Oh.
Okay, all right, now I want you to bring it out, okay, and down. Okay, good. Same thing with her head, push toward me and back. Okay, and I can also do spinal accessory nerve at this point in time since I'm testing this way, have her shrug shoulders and down, again looking for symmetry. And that basically goes through your range of motion for your upper extremities as well as your testing. Then I just start in a head to toe approach. Okay, palpating her head, any tenderness, have her tell me if there's any place I hurt, feeling for masses, noting the contour of her head, basically appears normocephalic, any gross abnormalities in symmetry, there doesn't appear to be any. Noting the texture of her hair, any balding, the presence, the color, is it clean, any parasites in the hair, any lesions on the scalp. Okay, noting female pattern, etc. Okay, also looking at her face, looking at symmetry of the face. Okay, also at this point in time, I could have her do some facial movements. Have her smile, frown. Okay, puff out your cheeks. Okay, close your eyes, don't let me open them. Okay, wrinkle your forehead. Okay, same sort of thing, looking for, again, for symmetry of movements. I could also do the fifth, that would be the seventh cranial nerve. I could do the fifth cranial nerve at this point in time, the motor component, have you clench your teeth real tight there. Feeling the temporal area, over the mandibular area. Have you move your lower jaw press it against my hand, and the other way, looking at the pterygoid function. Okay, and that would be your fifth cranial nerve in terms of motion. Okay, at this point in time, I will do the sensory part of with the head to toe, and I'm not going to test sensory of the seventh nerve, the anterior 2/3 of the tongue, for taste. It's not part of the screening exam. Okay, at this point in time, I would start in a head to toe fashion, and I'll begin with her eye exam. And I'll progress through the eye exam, looking predominantly external to internal. All right, as I look at her externally at her eyes, I note that she has the presence of eyebrows, the presence of eyelashes. I note to see if their eyelashes turn in, or they're inverted or everted. Okay, you might want to look that way a little bit. Okay, I also note that they are symmetrical. I note that the pupils, the iris, the cornea is clear, the sclera is white. Look at the conjunctiva. Okay, noting again that that is clear as well. I can also palpate up the lacrimal apparatus, looking for any drainage from the puncta. I can also palpate up over top, noting drainage from the puncta as well. Okay, at this point in time, I'll go ahead and begin and test for visual acuity. Okay, I'll take my Snellen card. I'll have her to hold it at a comfortable distance. I'll have her read all the way down the left, starting at the top down, until she gets to a line that she can comfortably read, and have her to read it binocularly. If she wore glasses, I'd have her to have those on, because I want to see what her functional vision is. So have her read from left to right after she gets to the line she can read.
428739.
Okay, and I would record that 20/20 vision in the binocularly. Then I would have her to take a cover, occlude her left eye, and read the same line.
Left, right again?
Yes.
I can't read.
You can move up to the next one.
937826.
Okay, and if she could read, she has to read a majority of lines to record her vision at that level. If she could only read part of it, if she could read all but one character, then you'd record it 20/20 minus 1, whatever. Okay, then you have her switch, cover the other eye, do the same thing.
4283 or 739.
Okay, again, it's best to have them always read left to right, because if you switch and have them read the other direction, people don't read that way normally, so some people may have trouble with it just on the basis of that. Okay, so that's visual acuity, second cranial nerve. The other part of second cranial nerve would be your visual fields. Okay, Beth, I want you to cover whichever eye you drop. You want to, okay? I'll get right in front of her at the same level, cover the same eye. Look right at my eye, Beth, and I want you to tell me when you see my finger coming in.
I can see it. I can see it. I can see it. I can see it.
Okay, would you switch and cover the other eye, please?
I can see it. I can see it. I can see it. I can see it.
Okay, and that would be visual fields by confrontation, and they're intact. Okay, again, keep in mind your visual fields have to be intact in order to test that in that manner. That's the second cranial nerve as well. The third part of the second cranial nerve that I'd want to look at would be the fundoscopic exam. Okay, I'd locate my otoscope, or ophthalmoscope rather, and I would use, in terms of, and you're not going to be able to really appreciate this, but I would be using the small light, the small circle to actually do the exam. Now before I go in, I need to look at her anterior chamber. You can do that one of two ways. You can take a pin light and actually sit out here to the left side and shine your pin light across and look to see if you should have a clear anterior chamber. There should be no blood or anything like that in the anterior chamber. I can do that from the lateral aspect. The test, as Dr. Carter indicated when he did your lecture, where you shine across and look for a shadow to see narrowing, is not very accurate, and mainly what you want to look for in the anterior chamber is the presence of blood. So it's probably just as accurate to sit out here from the side. The other way you can do is go on a black 10 or 11 on your ophthalmoscope and look at it from the side. Okay, you put it on black, 10 or 11, stand out about right here and looking at the anterior chamber. That doesn't seem to make any difference. Either way is fine. Okay, so then at this point in time, I'm gonna have Beth to scoot down toward the end just a tad. Okay. All right, and I'll have her to focus on an object across the room here. Okay, right on the wall. Okay, and Beth, my light may come in front of your eye, but just stay focused on what you focus on. Okay, remember to use the correct hand, and I will stabilize her head. Start in from out here. I have the red reflex. Okay, going on in. Okay, and I'm looking in. I see the vessels, the veins, the arteries. Okay, the veins are the larger, arteries are smaller. The arteries have a light reflex, looking for nicking, for cotton wool patches, for any exudates in the background. Okay, looking at the disc is clear, the margins are clear. Okay, the color is good. Okay, then I will switch my otoscope, my ophthalmoscope to the one with the grid on, and I'll have Beth to look right at the light, and I'll look temporally for the macula. Okay, let's look right at Beth, okay. And I see the macula, and I note that the presence of the macula, okay. Okay, and I'll repeat the same process on the other side. Now, what I'm going to do for you is just go through technique-wise. I'm not going to say all the structures. Okay. Again, stare straight ahead, Beth. I come in about 15 degrees. Okay, right around again, the disc. Nasally, the arteries, veins, etc. Okay. And that will be your fundoscopic exam. Okay, then to continue on with the eyes, I need to go through several things of your alignment types of things. So first of all, what I'll do is extraocular movement. Okay, extraocular movements are going to be 3, 4, and 6 in terms of your cranial nerves. Okay, what I want you to do, Beth, is I want you to follow my finger, and I'm going to tell you the muscles in her left eye. Okay, the muscles and nerves in her left eye. So I'm going to hold her at a gaze for a certain point, for a little bit longer than you would normally hold that gaze. The other thing I'll be looking for is for nystagmus while I'm doing EOMs. You'll get a little bit of nystagmus with severe lateral gaze, but you shouldn't see nystagmus with any other gaze. Okay, if you get tired of staring at my finger, feel free to look back toward the middle, or maybe I'll bring it in order to tell them. Okay, again, I want to be a comfortable distance. I don't want to go right up here. I want to ask her, is that a comfortable distance? And I usually, again, will stabilize head, and that probably comes from a pediatric orientation, but that way they can't turn their head when you go. Okay, keep in mind, I'm telling you muscles on the left, and you could transfer those to the right, okay? So if you look up here, okay, this is the superior rectus, 3rd nerve. Out here, lateral rectus, 6th nerve. Down here, inferior rectus, 3rd nerve. Okay, have her to look down here. That's the superior oblique, 4th. Out here, medial rectus, 3rd. And up here would be your inferior oblique, and that's 3rd as well. And come back to the center. Okay, then the other thing I could have her do after I've done that in terms of alignment would be to do the cover, uncover, and the corneal light. The corneal light, stare straight in front of it. There's enough light in this room, and there will be in most rooms, where you can look for the reflection of the room light on the eyes, and that will be the corneal light reflex, and you want to be sure it's symmetrical in both eyes. This test alone is not a real reliable test. It's just a test that you can use in addition to the cover, uncover test and the EOMs in terms of alignment problems. Okay, the next thing is the cover, uncover. And you'll do it for far and near objects. I'll give you that, Beth. I'm going to be looking at the uncovered eye at all points in time. All right, Beth, I want you to look at this pin light. Okay, I'm looking at her right eye, the one that's uncovered, and I'll take the cover off. I'm looking for any movement of the uncovered eye. A movement of the uncovered eye would either be an ESO if it moves in, or exotropia if it moves out. Any movement of the covered eye will be aphoria, and that is not something that we would worry about treating. Okay, you'll cover the other eye and uncover. Okay, and again, there's no movement. Now I'd have her to stare at a far object over on the wall and go through the same thing, covering one eye and the uncover. Okay, looking at the uncovered eye. Okay, cover and uncover. And again, I see no movement with the cover, uncover test. Okay, and that basically looks at your movement. The other thing you want to look at for your 3rd nerve would be your pupillary function. And if you think of your mnemonic, the PERRLA, that'll help you out. Pupils are equal and they're round, they react to light, and they accommodate. And the other part of that nerve is actually looking for ptosis, and I usually sort of eyeball that in the beginning. You want to see that her palpebral fissures, again, sort of look this way, her palpebral fissures are symmetrical on either side, that she doesn't have any ptosis or lid lag. They're the same thing. If one lid was down lower than the other, that would be a third nerve problem. All right, what I'm going to do is I'm going to do direct and consensual. All right, when I shine it in this eye, you see direct. Okay, and I'll shine this eye for direct. Okay. All right, now I'm going to do consensual. I'll shine it in this eye, and I'll watch the opposite one, and then I'll shine in this eye, and if the camera will go back to this eye, okay, we'll look for consensual reaction of the pupil, okay? And then I can also do accommodation at this point, use a non-light source. Light's a non-accommodative thing, so you want to just use your finger or the pen light. Beth, have you followed this in? The pupil should constrict and converge. Okay, and they did. And sometimes you'll have to come in a little higher so you can actually see the eyes. The key thing is that you don't want to hold them at that gaze for a long point in time. Okay, all right, at this point in time, we have taken care of basically everything we need to do with the eyes. Okay, now at this point, I'll move on to the ears. You want to get your instruments ready. Okay, in terms of the ears, I want to first, again, inspect. I want to look at the level of the ears, be sure that the top of the ears is equal with the outer canthus of the eyes. Note on both sides. I'm going to talk to probably one side, but note it on both sides, outer canthus of the eye. Also note the presence of the pinna, the tragus. Be sure that there's no obvious masses, and I'll palpate for any discomfort, any masses. Does it hurt when I move this at all? Yeah. Press on the tragus, see if that causes any pain, because if you get an external otitis, that might cause pain. Palpate the mastoid, see if there's any problem, any pain there. Feel for tophi, which are your gouty deposits, uric acid deposits, okay? And again, as I said, I would do that bilaterally. Okay, at that point in time, then I'd go ahead and do the hearing. Remember, there's three things we can do, and this would be your 8th cranial nerve. We're going to basically be focusing on the auditory portion of that. The vestibular portion you could test with Romberg or looking at nystagmus, and calorics is the most efficient way to test it, which we aren't going to do as a part of this course. So to focus on the auditory component, we'll do Weber, Renee, and then you could also have her occlude one ear and then whisper or use watch tick. I personally don't usually do that. If I find a problem with Weber or Renee, then I would have them referred for audiometry. Beth, I'm going to strike the 512 tuning fork, and I'm going to put it in the middle of your forehead, and I want you to tell me if you hear it loudest in your right ear, your left ear, or is it equal in both ears?
It's the same.
Good. Okay, and that would be right equal to left or no lateralization. All right, then with the Renee, put her on her mastoid, and you tell me when you stop. Okay, still here?
Mm-hmm.
Okay, and that would be air conduction longer than bone conduction. Repeat on the other side. Okay. Okay, and again, air conduction longer than bone conduction. Okay, then at that point in time, I would go ahead and I would get my otoscope. I would get the largest speculum that would fit comfortably in her canal. Okay, I can either hold this manner or I can hold this manner. Okay, she's an adult, I'll pull up and back, and a child, I'll pull down and back. Okay, as I'm going in, I'm looking at the external canal, looking to see if I see any discharge, exudate, cerumen. Okay, note the proper technique for holding, pulling up and back. Okay, see the canal, looking to see the presence of hair, a little bit of cerumen, the color, the consistency of it, it's soft, it's yellow. Okay, I can see the tympanic membrane, it's gray, and the light reflects in the anterior inferior quadrant, the umbo, long process of the malleus, short process of the malleus, pars flaccida, pars tensa. All landmarks are very well visible, no retraction, no bulging. Okay, and with the other ear, I'm going to illustrate the use of the pneumatic device, which I would only use in kids. Okay, okay? Now, with the pneumatic device, I would go in just as I did on the other side, except I need to change hands, okay? And I'm pulling up and back. Again, I visualize the same structure as I did on the other side, and I want to see movement of the tympanic membrane. So I press and let out, press and let out, and I see the tympanic membrane move in and out as I do that. If there were fluid behind the membrane, you would not be able to see movement. There'd be decreased movement, as well as you'd see an air fluid level as you looked in the ear, potentially. This is, again, pneumatic device would be something you would only use in children, and the people that have a pediatric focus or a family focus will need to demonstrate that technique. Okay, at this point in time, I'm going to move on to the nose and sinuses. Okay, again, external to internal. As I demonstrate in terms of looking at her nose, look for symmetry, look for the presence of two nares, occlude one, have her to breathe through the other, and out. Same thing. Okay, looking at patency. Also, I could go ahead at this point in time while I'm on an external focus and see if she has any tenderness over her sinuses, frontal sinuses, maxillaries. Any of that uncomfortable bit? Okay, transillumination, I would have a totally darkened room, and I could go ahead and do that. Transillumination is sort of one of those up for grab techniques as to how much information it really gives you. Probably history and percussing the sinuses gives you a fair amount. Some people also will palpate. They'll actually just sit here and sort of press on the sinus areas. But to actually illustrate transillumination, you can use a really bright pen light, or you can use a transilluminator that hooks on your diagnostic set base. And what you would do is have a totally dark room, which we don't have, so you're not going to see a thing, but I'll at least illustrate technique. Have her close her eyes, and I would shine the light right up in here, and she would light up like a jack-o'-lantern sort of right here. Same thing on this side. And then for the maxillaries, have her open, tilt head back, open mouth, light right up in here. Okay, and it would light up in the top of the palate. Same thing on this side, light up in the top of the palate. And that would be transillumination. Okay, then to look at her external, or internal nose rather, have her tilt back just a tad. Okay, grab the tip of the nose, insert your speculum, have her breathe through her mouth so you should have fogged up your lens. Okay, noting the septum is midline. There's no deviation, there's no excoriation. Note the mucosa, it's a little bit red in the oral mucosa. Any discharge, small amount of discharge, okay. Note the color of it, presence of hairs, presence of the turbinates. You'll probably see the inferior, you might see the middle turbinate, noting to see what color they are, if there's any bogginess or edema in the turbinates. Repeat the same process on the other side. Okay, looking for the same thing actually, that's right nary, as the passage is a little bit redder, a little bit more inflamed, with also a little bit more clear discharge. Okay, the other thing would note, if you see gray membranes, boggy membranes, that would probably support your allergy phenomenon. Okay, at this point in time, I move on to do the oral cavity and the pharynx. When I start the oral cavity, again, I would observe, I have to look this way, I would observe her lips, the color of her lips, any cyanosis, any fissures in the corners, okay, any lesions. And then after that point in time, then I go ahead and start my internal exam. Okay, now, as far as the internal exam, have her to go ahead and open her mouth. Okay, as she opens her mouth, I'm noting her teeth. And have you bite down, Beth, show your teeth. Looking for occlusion, seeing if there's some overriding in the front, which there should be, and the back molars are hitting together, okay? All right, I'm looking at her gums, looking for hypertrophy, bleeding, lesions, looking at the, you can go back together again. Looking at the buccal mucosa, looking to see if there is any lesions on the mucosa, soft palate, hard palate are intact. Raise your tongue up there. Okay, looking underneath the tongue, looking at the vessels, looking at, okay, just turn just this way. Looking at Wharton's ducts right here at the base of the tongue. Okay, also looking at Stinson's. Stinson's ducts are up here behind the upper last, and next to last molar. See the little blip there, that's Stinson's duct. Same thing on the other side, being sure these ducts are patent, that there's no major discharge from them. Noting for caries, noting the restorations that are in her teeth. Okay. All right. Having her say ah, uvula's midline, palate rises symmetrically. Okay, going back here, producing a little gag. Okay, and also we're going to look at her tonsils. Okay. Okay, don't seem to see any tonsils back there. What you would want to do is look for the tonsils. Tonsils are there, you need to grade them. You want to look at the color of them, the size of them. Is there exudate on the tonsils? Is there exudate running down the posterior pharynx, like some postnasal drainage or that type of thing? In terms of grading the tonsils, grade them 1 to 4. 1 would be the ones you can barely see. 4 would be the kissing tonsils that touch in the middle. 3 is almost touching, but not quite. There's a lot of kids walking around in normal everyday life with 3+ tonsils. 2+ tonsils, adults would typically have 1 to 2+ tonsils in a normal state. You would also want to note if there are no tonsils there. Gag reflex is one of those up for grab things. You can do it if you want, but it's not a real reliable thing. As long as the uvulus midline and the soft palate rises symmetrically with phonation, then your 9th and 10th nerves are intact, and you really don't need to worry about doing the gag reflex because it's not reliable. Okay, your posterior 1/3 of the tongue taste on that aspect is also part of your 9th nerve. We won't test that in a screening exam, however. Okay, the other thing that we would want to note in terms of the mouth would be sure that you've got an intact palate, particularly in kids. You may want to actually feel. And the other thing is in adults, you would probably want to go ahead and do a gloved exam, which I'm not going to do at this point, but have your 4x4 and your gloved hand and actually go in and palpate the entire oral cavity, palpate the tongue, move the tongue from either side, palpate underneath the tongue, noting any masses, varicosities, that sort of thing, because you can a lot of times pick up early oral cancer in that manner. The other thing I'd have her do would be to also do the 12th cranial nerve, the hypoglossal nerve. Have her stick her tongue out, see that it protrudes mid-line, look for atrophy, fasciculations of the tongue. Have her move the tongue from side to side, up and down. Okay, put it back in your mouth and press against my hand and press against my hand. Okay, that looks essentially at your hypoglossal nerve in terms of movement of the nerve, of the tongue itself. Okay, and that basically takes care of your oral cavity. Okay, at this point in time, then I would go ahead and go to the neck. Now, usually at the neck, before I start the neck, I'll go ahead and do the lymph nodes. I start the lymph nodes with the preauriculars, and since I'm very conveniently located over the area where the TM joint is, I'll also do that at this point. So first of all, I palpate. Before I have her do anything, I palpate. Do you have any tenderness there, Beth? Okay, then I have her open, and I feel for dislocation. Okay, close. Dislocation, crepitus, clicks, or pain as I do that. Okay, then I feel nodes. Preauricular, in front of the ear. Postauricular, behind. Occipital, over the prominence, occipital prominence in the back. Okay, then tonsillar. Submaxillary or submandibular, whichever you choose to call them. Submental under the chin. Anterior chain down the anterior aspect of the sternocleidomastoid. Okay, tonsillar right up here in the V sort of. Then I go down the posterior aspect of the sternocleidomastoid, and that's a posterior chain. And then I feel up the anterior portion of the trapezius for the other posterior chain. Okay, I also do the supraclavicular, start at the clavicle, feel on top all the way out, and infraclavicular, below the clavicle, all the way out. Okay, the epitrochlear nodes are going to be nodes you're going to forget if you don't do them at some point in time. Epitrochlear is the main time you're going to do an epitrochlear node would be if you've got some inflammation involving like a perineum will typically give you epitrochlear nodes. So for epitrochlear nodes, you'll usually feel them in this area right here, okay? Just sort of feel around right above the olecranon, and you'll feel epitrochlear nodes in between the muscles, sort of. And once you feel them, you'll never forget that you felt them. And you could do those bilaterally. Okay, then at this point in time, I'll go ahead and do the rest of the neck. Observe, palpate, trachea's midline, okay? And I'll sort of feel down there. And then I can do the thyroid. And I've even been nice today and brought water for Beth. Okay? you ideally have water the person can swallow. It makes life easier. You can do it from the anterior aspect or the posterior aspect when you palpate the thyroid. It's probably easier for beginners to do it from the front because you can see where you are. Okay, I found my landmarks. Thyroid cartilage is the top sort of cartilage that goes like so. Come down, cricoid or cricoid, whichever you want to call it's here, and the isthmus of the thyroid is right below that. So I will find that, there's your cricoid, and I'll just have her swallow normally. Go ahead.
With water?
Yeah, whatever. Okay, just have her swallow, and I'm just feeling with my thumbs lying very loosely over top there, just feeling the whole thyroid as she swallows. Now what I'm going to do is I'm going to displace with my thumb on this side, and I'm going to feel with this thumb. Okay, now Beth, you could take a little bit more water in your mouth there. Do you want some more water?
That would be great.
All right, why don't you have a little more water, and don't swallow till I tell you. Okay, now feel swallow, please. Okay, and I'm feeling a little bit of tissue, which is normal. You make it a little bit slide down. Then I'll compress with the other thumb. Let her have a little bit more water here. And then have you swallow it, Beth? And I'm feeling with this thumb on this side, okay? And again, you're feeling to see the consistency. You're feeling to see if there are any masses. You're feeling to see if it's enlarged. Feeling to see if there's any tenderness. And you're feeling to see if the thyroid is enlarged, you could go ahead and listen for bruits with your bell. If it's not enlarged, it's normal, then you're wasting your time listening for bruits, because the only reason you're listening for bruits is because of the increased vascular flow through the area. Okay? Then the other part of the neck exam per se, we've already done. We've already done your spinal accessory nerve, and we've done range of motion of the neck. So that would complete your neck exam at this point in time. Now, before I leave the head and neck to progress onward, I always think back through to be sure that I've gotten all of my cranial nerves that I'm going to do at that point in time. Now, I have not done sensory portion of the fifth nerve, but I will pick that up later on. 1 we didn't test, 2 we've done, 3, 4, and 6 we've done, 5 we'll pick up the rest of later, 7 we've done, 8 we've done, 9 and 10 we've done, and 11 and 12 we've done. And I usually verbally think through, or not out loud to the patient, but we'll think through and be sure that I've gotten that before I move on. Okay, at this point in time, I'll go ahead and move on to the anterior chest. And when I do the anterior chest, I'm basically going to do respiratory and cardiovascular together as I go through. Now what I'll do at this point in time, probably Beth, is to let you slip the top part down. How's this?
That's fine.
How's this? Is this cool?
That's,
No,
what do you
probably
want
need to slip
top?
the arms off.
Okay.
Slip the arms off. This is going to be your cover for
Okay.
now. You can hold it underneath your arms like they do at the doctor's office. You know,
Oh, great.
you know those fancy little things they have. Okay. All right. In terms of the anterior chest, as far as respiratory and cardiovascular, I'll start off by just doing general observation. Respiratory wise, I'm going to observe use of accessory muscles. I'm going to observe for any nasal flaring. I'm going to observe for general color. I'm going to observe the anterior to posterior diameter is less than the transverse diameter. Observing for barrel chest. Observing for any pectus carinatum, pectus excavatum, carinatum where it comes out, excavatum where the sternum goes in. General structure of the sternum. Also noting her posturing. Does that indicate to me that she's having respiratory problems? And cardiovascular wise, I'm observing to see if I see any pulsations, which I'll be able to see much better when I have her in a lying position, but I at least to think about that at this point in time. All right, once I've observed also respiratory movements, is she breathing thoracic, is she using abdominal muscles, a combination of the two, what is she doing at this point in time? Once I've done inspection, then I can move on in any format I choose to, whether I want to go palpation, percussion, or auscultation. It's not going to make that much difference. So I usually will go ahead and do palpation next. Okay, one other thing, let me say before I do that, one other thing as I sit and look at the anterior chest, I usually, I'm a female and male as well, will include the breast, and I'm just going to sort of talk through those with you in terms of the breast exam. I'd note with her just in a relaxed position like she is right now. I'd also have her put her hands on her hips. You don't have to do it, just have her put her hands on her hips and contract her pectoral muscles. And I'd also have her put her hands over top of her head to look at breast tissue. I'd look at symmetry of the breast. I'd look for any deviation of the nipples, any dimpling of the skin, any discharge from the nipples, any obvious masses, any obvious asymmetry. I look for all those things and I do the same thing in the male. Now the actual palpation of the breast tissue, I would do in a supine position with the hand above the head and the pillow underneath, and I'll show you that position as I lie her down. But then I would do the actual palpation for masses, checking in the circular motion and also checking for nipple discharge at that point in time, and also feeling for your axillary nodes. I can do the axillary nodes at this point in time, actually. I'll do the axillary nodes on this side, illustrate for you. Okay, have her to relax. Let me give her a hand right now. You just relax your arm down. Okay, you want her as relaxed as possible. And the best way to do your axillary nodes is to think of it in terms of sort of four or a cross section. So I palpate up and in, up and back, up and toward the front, toward the pectoral area, and then up and out toward the arm. And that will get your 4 groups of axillary nodes. And when you're feeling your breast tissue, you want to be sure that you go up into the tail as well. Okay, so at that point in time, then I'd go ahead and move to the palpation phase after I've done the inspection. Palpation, I'm just going to do general palpation, okay? And I'm just going to feel over the chest, see if there's any tenderness in any area. All right, then I'm going to feel for the point of maximal impulse or the apical impulse. Okay. The apical impulse on Beth is about 1.5 centimeters in diameter. Okay, it's located, okay, here's her angle of Louis, your second intercostal, third, fourth, fifth. It's at the 5th intercostal, and it's at the midclavicular line, which is exactly where it should be. Okay. Also at this time, I'm feeling to see if I feel any thrills, any pulsations over the precordium, and also tenderness, masses, those sorts of things as we go. Okay, at that point in time, once I've done general palpation and I've palpated for the apical impulse or the pointer maximal impulse, then I'll go ahead and percuss. Now, percussion on the anterior chest is a bit taxing, particularly in females with a lot of breast tissue. So it's not going to give you a tremendous amount of information, but you need to at least attempt it. So I'll do percussion. You're going to be predominantly over lung tissue, so you're going to have predominantly a resonant sound, except over the heart, which is going to give you a dull sound. And percussion, as far as the cardiac exam, is a chest x-ray gives you much more information, so most people don't include percussion. Sees it on. Okay, Beth, why don't you just sort of put the towel up here. Be sure you get the lateral aspects. Okay, and come around the other side, or you can get lateral from the posterior aspect. I usually do it from the posterior. Okay, got your towel here. We're good with this towel. Okay. So that would do the percussion aspect. Then the next thing that I would do would be to go ahead and listen. And you need to think through and talk out loud to whoever's watching you as to what you're doing, auscultation-wise. I usually listen to heart first and lungs second, because once you have taking deep breaths, then you're going to affect the cardiac sounds. So I'm going to tell you where I'm listening, the sites as I listen. I'm listening starting off with the diaphragm, second intercostal, aortic area. Pulmonic area, second intercostal on the left. Erb's point, third intercostal on the left. Tricuspid area, fourth intercostal on the left. Okay, let's do this one. Okay, and the mitral area, fifth intercostal, midclavicular line on the left. Switch to my bell. Come back up. Mitral, tricuspid, Erb's, pulmonic, aortic. Okay, I'll listen going up with I've got the bell, listen for bruits over the carotid. Beth, hold your breath, please. Holding the breath keeps you from hearing breath sounds. Breathe. Okay, hold your breath again. And breathe. And if I were going to listen to thyroid bruise, I could do it then as well. Okay, then I'll switch to my diaphragm. Beth, each time I touch you with the diaphragm, would you please take a nice deep breath in and out through your mouth, nice and slow. Be sure you listen over the right middle lobe, about the nipple line on the right. Laterally. Okay. 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 As I was listening in the cardiac cycle, aortic and pulmonic areas, or the base of the heart, I was hearing S2 louder, and at the apex I was hearing S1 as the louder of the two sounds. The diaphragm is going to pick up your high-pitched sounds. The bell is going to be more sensitive to your low-pitched sounds. I didn't hear an S3 or an S4. I didn't hear any splitting. I didn't hear any extra clicks or anything. S3 and S4 are low-pitched sounds, and you'd hear those better with the bell. I didn't hear any murmurs as I went up from top to bottom. The other thing is that in terms of her respiratory sounds, I was hearing predominantly vesicular sounds in the periphery, bronchovesicular, where the bifurcation occurs, and I didn't really listen over the trachea per se, which you wouldn't necessarily. I didn't hear any adventitious sounds, rales, rhonchi, wheezes, pleural friction rubs, none of those types of sounds. And as I said to you earlier, the carotid, as I listen over the carotid, I want to be sure that I don't hear any sound when she's holding her breath. And then that would essentially take care of your cardiac exam and also your respiratory exam in terms of auscultation. If I heard murmurs or an S3 or an S4, I might want to also listen up into the axilla to determine if I heard radiation of that murmurs into the axilla or into the carotid area. The other thing you need to keep in mind when you use your bell is that the surface of the bell contacts very lightly. You don't want to press it down and make a diaphragm out of the bell as you go through. The other thing to keep in mind is when you're having to take deep breaths in and out, you listen for a full phase of inspiration and expiration at each site, because inspiration and expiration, the length of them is important. Inspiration being longer than expiration in vesicular, and then the total opposite occurring in your bronchial sound. So you want to be sure that you're timing that. Also be aware of how your patient's looking when you're having them do that. You don't want to do that for 4 hours because it's taking you that long to listen and hear what you want to hear. So be aware that you might have to let them stop and rest. Okay. At this point in time, I basically finished the anterior aspect of the chest in terms of respiratory and cardiovascular, so I'll move to the posterior aspect. Okay, all right. Now, with the posterior aspect, what I'm going to do is go through the same sort of things that I did in the anterior aspect. I'm going to, again, visualize the basic structure. I'm going to look, and I usually visualize and sort of look at the same time. I'm looking for any lesions, I'm looking for masses. Okay, I'm looking for any gross abnormalities. I note that she's got a tan in terms of describing skin. I note any curvature of the spine, be it lateral curvature, scoliosis, kyphosis, lordosis being in here, kyphosis up here, or scoliosis being the lateral deviation. I also go ahead and palpate down, have her to tell me if any of that is tender or if I feel any abnormalities as I go down. Okay. Okay, also look at the level of the scapula as I'm looking back here, okay? And then I can go ahead and do CVA tenderness, which is really going to tell me tenderness of the kidney, and it's going to relate to the abdominal exam, but you do it while you're on the back. Beth, if this is tender, you let me know. Okay. All right, then the next thing that I would do is, again, note the respiratory movement, note the diameter, sort of all those kind of things over again. Then I would go ahead and progress to palpation. And I'd again do general palpation, muscle mass, any tenderness, noting temperature, moisture, diaphoresis of the skin. Beth, any of those tender, anything tender? Okay, I don't feel any masses. Okay, then at that point in time, I go ahead and do the other things that involve palpation. And one of those is fremitus. Now, Beth, what I'm going to do is touch you with my hand, and each time I touch you, you can say 99 or you can say Mickey Mouse, or you can rotate between the two since it gets boring saying 99. Okay.
Mickey Mouse, 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 Mickey Mouse.
Okay, you can stop now. Actually, let's do one on the lateral. So Mickey Mouse. A couple more Mickey Mouse.
Mickey Mouse, Mickey Mouse, Mickey
All
Mouse,
right, wonderful. All right, you'll note that I'm comparing the feeling of fremitus from side to side. I'm feeling vibrations, and it should feel symmetrical from side to side. You'll note that I started here, came down, and flared out because you don't go over bone because that's going to change your fremitus. You'll note also that I switched to the ulnar aspect when I got to the level of the diaphragm because it's easier to delineate where the level of the diaphragm is. And you saw where I stopped, and that's basically where the level of her diaphragm is. The other thing is if you had a solid tumor under here, then that would transmit, that would increase the fremitus coming through. If you have increased air, like somebody with emphysema or COPD, then that would decrease the sound you would see transmitted, so you wouldn't feel as well. If you have somebody with a big barrel chest, decreases the fremitus. Okay, now that gives me a general feel for when I go on to percussion where the level of her diaphragm is. The other palpation type of thing I can do is respiratory excursion or thoracic expansion, whichever you want to call it. Go around the widest part, take your thumbs, pinch up the skin evenly in the middle, okay? Now have her take a deep breath and let it out. One more time, you're watching for my thumbs to move apart and that they move symmetrically, okay? Fine, that's, again, symmetrical and adequate expansion is what you're looking for. At this point in time, I go ahead and percuss. Again, I'm looking for resonance, and I'll follow the same pattern. I'll start here, go down, and flare out. Okay, and I get the lateral aspect here. Trying to go in your intercostals as much as possible. Lateral aspect on this side. Okay, and we're past lung tissue now. All right, that's general percussion. She's resonant throughout. At this point in time, I'd go ahead and do diaphragmatic excursion. Diaphragmatic excursion is looking essentially at what kind of volume, what kind of expansion the lung has. Somebody with COPD would have less respiratory excursion or a lower number than somebody that's normal. Normal is 3 to 5 centimeters. What I'm going to do is have her take in a deep breath and hold it. When she does that, that moves her diaphragm down, and that'll give me my bottom line. Then I'll have her taking a deep breath, blow it all out, and hold it, and that will move the diaphragm up, and that'll give me my top line. I'll measure the distance between those two lines, and that distance will give me the respiratory excursion. You should do that on both sides. I'll only do it on one side for illustrative purposes, but it should be done on both sides, and it should be basically the same on both sides. It may vary in terms of its height, but it'll be basically the same. You don't have to have a pen. If you've got a mole you can use, that's fine. Try to use something that washes off. Okay, I want to get well up in, let's see, which side can we see better here? Okay, that's wonderful, that's wonderful. Okay, I want to get well into resonance when I start this, okay? Because I don't want to have a hard time telling my notes. And I usually will take, say, 3 of my fingers and kind of put them in the intercostal spaces like that, and then tap down them, okay? All right, now Beth, what I want you to do is take in a deep breath and hold it. Hear the difference? Okay, breathe, Beth. Okay, so I'm gonna mark essentially right in that area. Okay. Now, Beth, I want you to take in a deep breath, and I'll start from this line and I'll come up. I want you to take a deep breath and blow it all out. And hold it. Hear the difference? Okay, breathe, Beth. Okay, then I will mark the other. Beth has these lovely marks on his back here.
permanent marker.
Permanent marker, no less. Then I would take my centimeter ruler and I would measure it, and it's about 4 centimeters ballpark of, which is within the realm of normal. I would also, again, repeat this on the other side, which I'm not going to at this point in time, but I would repeat on this side as well. Okay, at this point in time, then that essentially completes your percussion. Now I need to auscultate. With the diaphragm, Beth, each time I touch it, you'll take a deep breath in and out through your mouth, nice and slow. Okay, I was moving a little bit faster than Beth was breathing, but you would really need to stay for a full time at each place. Okay, at this point in time, that basically completes your anterior and your posterior aspect cardiac and respiratory exams. At this point in time, I'd go ahead and move to her abdominal exam. And so for her abdominal exam, I would have her to go ahead and lie down for me. And I will get the sheet. On your feet. Okay, we'll put the sheet on her. We have at least 32 degrees in this room. We try to keep our patients comfortable. Okay. Now for the abdominal exam, what I'm going to do is attempt to expose basically from the nipple line to the symphysis in that basic ballpark area, okay? And to have her to just put her arms to her sides, nice and relaxed, okay? Okay, for the abdominal exam, we'll start with just general inspection, okay? The first thing we're going to notice contour. And well, let me back up a second before we start the abdominal exam. I need to say to you, and you'll need to do this for me also when you start to have the person lie down, that you would again repeat your cardiac exam in a lying position. You go through all of your different auscultatory areas. If you heard anything abnormal, you may want to roll them over in the left lateral decubitus position to listen as well. But you always want to listen sitting and lying. Now, whether you use left lateral decubitus would depend on whether you heard an abnormality as you listen to the heart in the sitting or lying position. The other thing you do would be your breast exam. And let me just illustrate. Beth, just take your hand. And I would have a pillow right under Beth's shoulder here, and that would spread the breast tissue out so I could actually do the breast exam at this point in time. Okay, now let's move on to the abdominal exam. All right, in terms of abdominal exam, I'm looking at the contour. All right, I usually get down and look sort of across here at the contour, look for pulsations. Okay, and I can see her aorta pulsing here, which is normal in a thin person. Her contour would be flat to possibly a little scaphoid, but basically flat. Okay, and I also would usually eyeball up across the chest at this point in time too to see if you've got any major pulsations around the apical area, because you can see them better in a lying position. Also noting presence of any abnormal color like jaundice will show up really well. Vasculature that's very prominent, like with somebody with cirrhosis. Also note presence of scars, if so, where they are, and describe them well healed, whatever. Presence of stria, presence of any sorts of things on the abdominal. Look for respiratory movement of the abdomen. Look for movement, peristaltic movement, which normally you won't see much of. Normally the only thing you're going to see is the aorta pulsing. If you see peristaltic movement, that may indicate if you have a history that it leads toward a valve obstruction, the peristaltic movement would help to substantiate that. Okay, so I've looked, I haven't touched anything yet, I'm still looking. Before I actually touch anything, I want to listen. That want to be my first thing because I don't want to disturb the internal contents of the abdomen. The other thing that I'll usually do is look at abdominal musculature before I touch. I usually have them to raise their head, and that'll tighten these rectus muscles. And I can look to see if I see any bulging in between, and then later when I palpate, I'll have her to do the same thing and actually feel there. Okay? At this point in time, I'll go ahead and listen. I'll listen first with my diaphragm, and I'll listen in all 4 quadrants. Okay, what I'm hearing in all 4 quadrants is basically vowel sounds, and try to just let the stethoscope lay there itself. As I'm listening, I'm also noting the umbilicus, and I can see that her umbilicus is midline and there's no herniation or anything around the umbilicus. Then I would go ahead and switch to my bell. Listen over the aorta, midway between the umbilicus and the xiphoid. Aortic buoys. Renals. midway between the symphysis and the umbilicus for your iliacs. Then you can go on over the groin with the femorals. Come back up over the liver, between the liver and the umbilicus. Listen for venous hum, which would sound just like a brewery. Don't hear any of those things. Okay, then I would go ahead and do percussion of the abdomen. General percussion for tympani. Playing the drum here this morning. Okay, gastric air bubble, louder tympani. And if you had a bladder full, you'd get a dull sound. That was nice. I didn't ask Beth to empty her bladder before, but I didn't really percuss any dullness. Sometimes you'll percuss dullness over the bowel as well. Okay, then once you've done general percussion, then you need to percuss out the liver, midclavicular line. Okay, midclavicular line, I usually start well into tympani and go up. Be careful when you get to the costal border that you don't confuse that as your first dull sound. I'm going from tympani to dull. That's the costal border. See, that's still tympani. That's dull. Okay, everybody hear the difference? Sure they do. Okay. All right. So right there's that one. Okay. Then I start well up in resonance and come down. Resonant, no problem with that. Everybody hears the difference. Resonant, dull. Mark it. Pull out my handy centimeter ruler or use my fingers, which is what one normally does. Measure. I get a span of about 9 centimeters, which is normal. Anywhere between 7 and 12 would be normal. Liver size tends to relate to lean body mass. Men with much more lean body mass tend to have larger livers. If it's smaller than the 7, you don't really worry about it. Okay, the other thing I want to percuss is spleen. Now there's 2 ways you can percuss the spleen. We can go slightly posterior to the mid-axillary line. Okay, percuss. Okay, you get a little bit of dullness. Okay, but not much. And you really will only get one interspace of dullness. The other thing you can do is sort of a screening thing. Go to your anterior axillary line. Find your last intercostal space. Percuss in it. Hear that sound? It's sort of in between a resonant and tympani sound because you're getting the reflection from the gastric air bubble. Have Beth take in a deep breath and let it out. Do that a couple of times. No basic change in my percussion note. It stays basically the same. If it got markedly dull when Beth took in a deep breath, then that would be the spleen coming down, and that would indicate to me that I had an enlarged spleen, which I will follow up on when I do palpation as well. Okay, then I would move on to palpation. Do general palpation, light, over the abdomen. If she had a complaint in a particular area, I would tend to not focus on that area first. I would palpate that last. Watching her facial expression. If I were having trouble with her being relaxed, I'd raise her knees up. I'm not going to raise her knees up for this because you're not going to be able to see as well if I do. And she's reasonably relaxed. Here at this point, I can never raise her head again. Palpate up the rectus muscles to see if I feel any diastasis recti or separation, which I don't. Okay, then I would go on to deep palpation. Going through all the quadrants, sort of in a circular motion. Tenderness, masses, any fluid. Okay, anything of that bother you? Okay, then I go ahead and palpate the liver. Several techniques, let me just illustrate. Middleton's technique, which is the one I'm not going to use. You curl your fingers around like so, or you can use a bimanual technique where you go up under like so, or you can use a technique I'm going to use where you put a hand behind the back, relax down, hand behind the back, and then I go up under. Keep in mind, not long fingernails, and you want to have warm hands, and obviously warm stethoscopes, which I should have said to you before, and good lighting, which we have plenty of in this room. Okay, I'm going to be pressing up with the hand behind, and I'm going to be going up under the costal border. I'm going to have her take a deep breath, and when she takes a deep breath, I'm going to go back up under underneath, and then she'll let it out, and I'll feel the liver edge. Now, keep in mind where we've palpated or percussed her liver, though, it's up in the second intercostal above the costal border, which probably means we may or may not feel it, depending on how relaxed her abdomen is. Okay, take a deep breath, Beth, and let it out. Okay, another deep breath, and let it out. Okay, I was pressing fairly hard, as Beth can say, and I can barely feel the tip of it, but she's fairly relaxed. Do the same thing for the spleen. And if I haven't percussed it, I'm probably not going to feel it, okay? Come over and take a deep breath and blow it out. The other thing you can do is sometimes roll them onto their side to feel the spleen, but most of the time you do okay with it this way. Okay, let it out. Okay, that's great. Okay, the other thing that I typically will include will be to do inguinal nodes and femoral pulses at this point in time. Okay, the other thing you can do is to try to palpate for kidneys. You're probably not going to feel kidneys, but the technique would be press up with the back hand and down with the top hand and sort of try to trap. Okay, again, it's not real comfortable, so I'm going to be nice to Beth. Okay, and same thing on the other side. Sometimes you will feel the kidneys, but typically not unless they're enlarged. Bladder, if it's full, again, you might be able to feel. Colon, you may be able to feel if it's full of stool, but those are the only things that you should normally feel in an abdomen. You should not feel a spleen, you won't feel a pancreas, you shouldn't feel a stomach, and those are the only things. Am I supposed to stop? Okay, to complete the abdominal exam, we'll do the reflexes. Okay, in the abdominal reflexes, you do upper and lower extremities, and you can use your finger or you can use the end of a reflex hammer. You stroke in toward the umbilicus and it should move back toward your finger. So if we can get a close up of the umbilicus here. Okay, and I'll stroke in toward it. Okay, toward it. Okay, you know, people that are ticklish, they jump before you get to the umbilicus. But at any rate, you're stroking toward, and you're getting movement of the umbilicus toward the direction that you stroke. Okay, the other thing that I need to illustrate to you in a lying position, which is totally unrelated to the abdomen and is not a technique that's used that much, but before you sit the person back up, I need to at least illustrate how you do it. You'll need to illustrate this for me in your final checkoff, and that is how you go about doing jugular venous pressure, jugular venous pulsation, how you measure that, looking at jugular venous distension, looking at function of the right atrium, or the right side of the heart. I'm going to illustrate on Beth's left side because it's closest to you. In somebody that does not have an elevated JVP, it's very difficult to illustrate. So I may do a little play acting here and mark things for you that really aren't distended just so you can see how to measure them. But you do need to be familiar with this technique. All right, I just want to cover the abdomen back up. Okay, you have a bit of the turn, have the camera come in close to the neck here because we're going to be using this space from here to here. Okay, now here's the carotid right here. Okay, and then our external jugular runs up right there. And the internal jugular is what you want to be using, and it's in between your carotid and your external. So I look for the top of the pulsation, and I should have her elevated about 30 degrees, which she's really not, but we'll pretend she is. Here's external pulsation, carotid pulsation. Let's say her internal goes to about right there, top of the pulsation. Okay, then I'm going to come over, find the angle of Louis, which is right here. Take a straight edge, bring it over from the angle of Louis, drop another straight edge down to meet the top of my mark. Okay, and this thing isn't marked all the way out to the end. It's got about 1 centimeter, so we're talking about 2 centimeters for Beth's measurement of her JVP. And anything above 3 would be considered abnormal. And you would repeat the same thing. I'm not going to for this purposes, but you would repeat on the right side as well. And that would be measuring jugular venous distension or jugular venous pressure. And you'd record it as 2 centimeters above the sternal angle with the head of the bed elevated at 30 degrees, if it was. If it's elevated different than 30 degrees, then record the amount of elevation. Okay? A lot of people will just record there is jugular venous distension obvious, or there isn't any if you see it above the clavicle. So you won't see this used a tremendous amount. All right, now what I would like to do next is to go ahead and do her pulses. Okay, and probably the best thing to do with Beth at this point in time is to let her have her gown back. Okay. And let me grab, you hold on to the gown, I'm gonna grab this. Okay, there we go. Okay, pulses, again, you're gonna be doing them bilaterally. I'll start with down here, okay, radial pulse. And whether you wanna feel them both at the same time or you wanna go side to side, if you're afraid that, a lot of people will feel both at the same time, but if you're afraid your sensation on your fingers is a little bit different, then you can go side to side. So, radial, radial, ulnar, ulnar. Some people won't have ulnar pulses, but you need to feel for them. Okay. Brachial. Brachial. Now some people will feel up in here for your brachials, but you can usually feel in the medial aspect of your antecubital space. Okay, now I can feel temporals, carotids, one at a time. Okay, and I've already done her femorals, go to the lower extremities. Actually, I think you lose your sheet. Give you back your gown, take your sheet. Okay, all right. Starting here with their dorsalis pedis. Some people again won't have those. Okay. Posterior tibials, inner aspect, medial aspect. On the medial malleolus. Same thing on this side. Popliteals. Okay, while I'm back here, I can also feel popliteal nodes. I'll feel for those first, and then feel for popliteal pulse. And I usually feel lateral and medial because where the textbook says it's supposed to be for popliteal pulse doesn't always hold true. Popliteals are sometimes difficult to feel. If you can't feel a popliteal, but you can feel dorsalis pedis or posterior tibial, then you're fine as long as you can feel the most distal pulse. Okay, same thing, nodes first, okay, then pulses. Okay, that basically takes care of going through pulses. The other thing you might want to do would be a radial-femoral comparison. Okay, they should be beating at the same time. If you had somebody with coarctation, you can sometimes just pick it up with femorals alone because the femorals will be real weak, and also the femoral and radial comparison would not be together if you had coarctation. Coarctation should be picked up before the child leaves the nursery, but it doesn't always happen that way. There have been 20-year-olds with coarctation picked up. So always be real careful to do that, or to do arm and thigh pressures and compare them. Okay, then at this point in time, what I would do is go ahead and do your musculoskeletal things with your lower extremities. It's easier to do those with the person lying down because their hips are, it's easier to manipulate the hips with them lying down. So I do general range of motion first. Okay, Beth, have you just move your legs apart and together. Okay, you bend your knees up on the table. Okay, now straighten back out. Okay, now raise your one leg at a time. We find raise it up and put it down. Raise it up and put it down. Move your ankles up and down and rotate them around. Okay, good, very good. All right, then I go ahead and do strengths in those. All right, have you push against my hands, pull your legs together. Okay, try to raise your leg up. Try to press it down. Try to raise it up. Try to press it down. Okay, and you bring your knee up. Bring your knee up. All right, try to straighten your knee out. Okay, try to bend it up. Bend your knee up. Okay, try to bend it. Pull it.
What am I supposed to do?
Try to bend your knee.
Bend your knee.
Bend, flex your knee. Flex. There we go. Okay. All right, push your foot down against my hand. Pull your foot up. Okay, pull your foot up. Press it down. Okay, now try to straighten your leg out. Okay, try to bend it at the knee. Okay, we're getting there. Okay, All right, that basically takes care of doing the movements. Now, I would also go ahead and do sensory component with the person lying down. It's just easier for you to see and easier for me to get to. Okay, so I'll start off with light touch, and I'm going to do point localization with that. Point localization is a higher cortical sensation, and then the actual light touch is one of your primitive or primary sensation. What I'm going to have Beth do at the points where she can reach to do it is to point to me. When it gets down to your feet, you don't have to sit up and point. Just say left foot, right foot, whatever. Okay, I'll have her close her eyes, and I want to be sure and touch. Keep in mind that I had never to do the sensory part of the trigeminal or your fifth cranial nerve, so the ophthalmic, the maxillary, and the mandibular portions. I want to be sure and test those. I will not maintain any particular pattern, but I will progress hitting at least here, here, and here, 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 and here, 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 and here, 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 and here, 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 and the 3 areas of the trigeminal. Okay? Now, Beth, each time I touch you, if you would point to the areas that you can. Okay? And your eyes are closed. You want to get the hair back.
Left foot,
Good.
right foot. Above the left knee. Above the right knee.
Pretend you don't have a gown on.
Left shin. Right shin.
Okay, that should take care of it. That should have all the areas. Then I would go ahead with sharp and dull, which I have my trusty needle. You could also use a clean safety pin as you throw it in the trash afterwards. And I'm going to do sharp everywhere, and I'll throw in dull now and then as a validator. And I'll go through the same areas that I went through before. Before she shuts her eyes, though, I want to tell her what sharp and dull is. That's sharp, and that's dull. Okay, I will try not to bring blood on the person. Okay, all right, are we ready?
Mm-hmm. Sharp. Dull. Sharp. 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 Dull. Sharp. Sharp. Dull. Sharp. 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 Dull. Dull. Sharp. 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 Dull. Sharp. 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 Dull. Dull.
I'm not going to do sharp through or down because I may gouge her, but I would do sharp, 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 okay? Okay, that takes care of your pain sensation. If you had a problem with pain sensation, then you might go ahead and do temperature testing as well. Little blood, it was a clean needle. Okay, you might also go ahead and do temperature testing if you had an abnormality in terms of your pain sensation, and then you could get your hot and cold test tubes. All right, then vibration or vibratory sense. Beth, you tell me when you feel the vibration. I'm using a 256 or a 128, either one.
I feel the vibration. Feel it everywhere. Feel it on my right ankle. Feel it on my left ankle.
Okay, and if I wanted to see if she was diabetic and she's losing vibration, because that's one of the first senses to go, then I would have her tell me first, do you feel it?
Sure do.
Okay, tell me when you stop. And I could go through that with all the different places to give me sort of a feel for how much vibratory sense she's lost. Next thing I could do would be position sense. Okay, Beth, I want you to shut your eyes, and I want you to tell me if your great toe is moving up or down. Oops, I missed it, okay?
Up. Up. Down. Down.
Okay, be sure you don't do this number because you don't want to do a pressure sensation, and be sure you don't touch the toe next to it. Same thing on the opposite foot.
Up.
okay? And I would go to the thumb, do the same thing. It's a little bit harder to do on the thumb, but this is up, Beth, and this is down, okay?
Up, down,
Okay,
up, down, down.
okay, great. All right, and that would take care of position sense. Then the last sense that I need to do is the higher cortical sense. And you can really do one of these, and if one of them's intact, they're all going to be intact. And we've already done point localization. So the other things we can do are stereognosis. Beth, I want you to close your eyes. I'm going to put something in your hand, and I want you to tell me what it is.
The nasal speculum.
The nasal speculum. You would not use
my nose.
you would not want to use this on your normal person. You have to be sure what you're giving them to feel is something they can tell. All right, Beth, I'm going to put something in your other hand.
It's a key.
It's a key, okay? And is it General Motors or not? Never mind. It's quite all right. Subaru, there, okay. All right, so stereognosis is intact. All right, now let's go ahead and go through graphesthesia. Beth, I'm going to draw a letter or a number in your hand, and I'm going to draw it facing you, and I want you to tell me what it is.
H.
Very good.
8.
Very good. All right. Next thing would be 2-point discrimination. 2-point discrimination, different parts of the body discriminate 2 points at a different distance apart. So pick the parts of the body you want to use and remember. I typically will use like the back of the hands and the dorsum of the feet. And about 4 millimeters apart would be when they should be able to discriminate 2 points. So if you're real close together and they can't discriminate, it's not because they're abnormal, it's because you're too close together. So Beth, I'm going to tell you, this is, just relax. This is 1, that's 2. Can you tell me? Okay, I want you to tell me when I touch you whether you feel 1 or 2 points. Let me see, let's try that again, all right?
1, 2, 2, 1, 2, 1.
Okay, now you can see on camera, that was 2, but it was so close together she couldn't tell. All right, Beth, tell us 1 or 2.
1,
Okay, that was 2, but I was too close together, so I'll move apart a little further.
2.
Okay, and she can feel 2, so that gives you a feel, that's normal. Okay.
2, 1, 1, 2, 1.
Okay, down to her feet.
1, 2, 1, 2. Do that again. 1, 2, 1, 2.
Okay, 2-point discrimination is intact. Okay, that takes care of your higher cortical sensation. And that basically takes care of your sensory exam. All right, at this point in time, what I have to do left is predominantly neurotypes of things. So what I'm going to do is have her to sit up for me, and I'll do her reflexes in sitting, and I'll tie you down after you sit up. Okay, at this point in time, I'll start, before I do reflexes, I'll do cerebellar types of things. Okay, Beth, I want you to just take your hands and come back and forth like this for me. Okay, rapid alternating movements, dysdiadochokinesia, if she couldn't do that, you have problems with that. Okay, now, I'm going to put my finger here, and I want you to touch my finger and your nose with your finger, okay? Very good. Okay, now, touch my finger and your nose, close your eyes and do the same. Very good, okay? Now, have you take your hand out to the side and bring it in, close your eyes please. Touch your nose. Very good. Other hand. Very good, excellent job. Okay, take your thumb and oppose it to your fingers. We actually did this at the beginning of the exam, but I'll put it together here for you because not only is it coordination, but it's also range of motion. Okay, other hand please. Okay, very good. Can you take your heel and run it down your shin? Other one. Make a figure 8 in the air, please. Okay, the other foot. Very good, very good. Okay, and that basically takes care of your cerebellar rapid alternating movement types of things. Okay, now go ahead and do reflexes. Oops, got another finger down here. Okay, put your finger basically where you'd be feeling your radial pulse. You can either strike on your finger or you can strike above your finger, okay? And you're gonna get sort of this movement. You want them relaxed. Okay, I don't know if you can see that.
You can.
Can you? Okay, there we go. All right, that's brachioradialis. Okay, biceps, feel the tendon. Get the Popeye effect here, okay? Just relax. Okay, you can see it. Flexion of the arm. The other way you can do that one is you can hold, I'll illustrate the other way on this side, I believe it'll be better. Okay, you can hold like so, put your thumb there on the tendon, and you'll get the same flexion, okay? All right, then the triceps, you need to hold it, just let the person relax, okay? And you'll get extension. Same thing on the other side. Okay, relax back, and hold it. Okay, extension, those are probably plus 2 to 3s. Okay, then your patella. Okay. Relax. Okay. All right. Ooh, Achilles. A little gravitation. Okay. Okay, you press down a little bit on this line. Okay, just relax a second. Okay. There. Other one. Relax it. Let me just push it up. Okay, there we go. There's your Achilles. While you're down here, go ahead and also do clonus. Have it relax, just press up and it should fall down. If they clonus, it'll beat down, but just push up and let it go. Push up, let it go. Push up, let it go. And clonus you're only gonna have with hyperreflexia or 4+ reflexes. Okay, plantar and Babinski. Normal plantar response, stroke up here and across, the toes flex, okay, great toe and everything will go down. If you have a positive Babinski, then what will happen is when you do the same stroking, the toes will fan, the great toe will go up, okay? So we come up and across. And the final resting state is the toes flexing. Same thing on the other side. Okay, same response. People that are ticklish on their feet, you need to go fairly firm with the reflex hammer or you're going to get a response you don't want. Okay, so once you've done your reflexes, you grade them anywhere from 0 to 4. 0 being they're not there, to 4 being hyperreflexia. The thing you need to keep in mind is if you can't elicit a reflex, that doesn't mean it's not there. So if you think it's your technique, because if people aren't relaxed, it's hard to elicit reflexes. So if you think it's your technique, then just put unable to elicit. And you also, we've done your abdominal reflexes in terms of superficial prior to now. And a cremasteric you would do on a male where you stroke the inner aspect of the thigh and the testicle on that side would elevate. Okay, at this point in time, that essentially finishes our reflexes. What we can do now is to have her to go ahead and stand up for us. Okay, the first thing I want to do is Romberg because I want to get a sense of how much balance she's got before I go ahead and do anything else. So I'll have her to stand there, okay? Put your arms out, Beth, and turn your palms up. Now this is going to be testing for pronator drift. What I'm looking for is one arm to go down and pronate if she had a weakness on one side from the paresis, okay? Now her close her eyes and stand there and look for swaying. Okay, cerebellar you'd sway with eyes open and closed, but if you're talking posterior column problem, you'd sway only with your eyes closed. Okay, she doesn't seem to be swaying. We don't have any pronator drift. Okay, Beth, you can open your eyes. Now I know she's fairly good balance, so I can have her to do her other stunts she's going to do for me. Okay, Beth, why don't you walk just normally to the end of the exam table. Okay, and turn back and walk this way, heel to toe, the tandem gait. Okay, do not hold on to the table while you're walking. Okay, now we'll turn around and have her walk back on her toes. And here you're looking for their ability to do this coordinated, not fall, not, balance, coordination, symmetry types of things. Okay, now could you walk back on your heels? Okay, now could you sort of step back to the center just a tad, and I want you to hop on one foot, and on the other foot, and on both feet. Okay, can you do a deep, do you have any problems with your knees? No, not till now. Okay, could you do a little bit of a shallow knee bend for me there? Okay, very good. Okay, at this point in time, I can also do any scoliosis evaluation that I'd want to do. I'm trying to, yeah, probably. Okay, now in terms of scoliosis, I'm going to look, let's see, let's do this here a second. Okay, scoliosis, I'm going to look at the level here, I'm going to look at the level of her hips, and I've already palpated down. So now I want her to, Carrie, have you got room? You're going to smash your head on the table? Okay, so I have her bend over, hang her head down, and I want to look again across here. The level of the scapula should be the same, level of the hip should be the same, and I shouldn't see any humps from side to side, and this level is the same. Okay, that's great. Okay, and that basically would be the posterior aspect. The other thing that I should be doing as I'm thinking through this exam, as far as a joint exam, we've talked about going through just range of motion, but you also need to look at joints, particularly if somebody has a complaint with a joint. Look at joints in terms of inspecting for size. You can have a seat actually. Inspecting for size, for symmetry. Is there any redness in the joint? Is the joint hot to touch? Do you feel an effusion in the joint? You also might want to note the joint as far as any asymmetry of any deformity of the joint. Of course, you've done range of motion. Feel for crepitus in the joint that you might actually feel. You might hear clicks. You might hear them with the naked ear, or you could potentially even listen to joints. Most people don't listen to joints, but you can. The other thing in terms of looking at your overall musculature, you need to note for muscle tone, you need to note for any tremors, fasciculations, note the difference in terms of atrophy of muscle groups, one versus the other. You wouldn't normally measure muscle groups unless you looked at them and eyeballing them, you saw that there was some asymmetry that you would like to actually measure further. Okay, at this point in time, I think we have completed Beth's physical exam this morning.